I'm going to go back. I'm going to go back with the definitions since, no, that's not what I want. This is the weirdest thing, y'all. I'm sorry. Present now. Window. All right. Are we back on? Can someone just say yes if you're able to see now?
Yes.
Yep.
Thank y'all. Okay, thanks for bearing with me. Okay, I'm just going to go back to these definitions, because I do want to make sure that they record for everyone. And thank you for reminding me that. We said a primary chronic disease of the brain, reward, motivation, memory, and related circuitry is addiction. Okay, someone in the process of using a substance to excess is going to be intoxication. When a person no longer responds to a drug in the way that the person initially responded and they need a higher dose to achieve the same effect, that this is going to be tolerance, and this is a huge key when it comes to addiction, okay? Like I said, in the DSM, it does show they have to have intoxication, tolerance, and withdrawal. The process of safely and effectively withdrawing a person from an addictive substance, usually under medical supervision. Of course, this is detoxification. All right. And of course, this is where we're going to see our patient in the acute care setting. So to start off, I know I have one more slide here with the definition, but with detoxification, I just want to quickly mention that two of the big drugs that we're going to see people detox from in the acute care setting is going to be alcohol and benzodiazepines. Okay, a lot of people think opiates is one that we see, or heroin within that opiate, under that opiate column, I guess you could say, with heroin. But actually opiates, and we're going to discuss this a little bit further in a second, but with opiates, they have a lot of physical problems. They feel like crap. It's like they have a case of the really bad flu. So usually, and they are wanting to use again so badly. So usually they don't make it through at home, and that's why sometimes they'll admit them. But physically, they don't. It's not physically dangerous detox or not. So they are able to do it at home, but usually people don't make it. Make it meaning they don't use again before. Okay, if that makes any sense. And we'll talk about that more when we get to opiates. And then the last definition, the recurrence of alcohol or drug-dependent behavior in an individual who has previously achieved and maintained abstinence for a significant time beyond the period of detoxification. And this, of course, is relapse. All right, so let's talk a little bit about epidemiology. Okay, some of these numbers might be a little bit different from your book because these are a little older and I haven't updated them, but they're going to be fairly close. And like I said, I never test on numbers. So, so over 50% of Americans over 12 years old drink alcohol. I just think these are really eye-opening statistics, so I like to share that with you. So that's about 17.6 million are dependent on alcohol. About 16% of the population has alcoholism, and 80% or more of the alcohol consumed in the United States is actually consumed by people with alcoholism. Rates of binge drinking and heavy alcohol use are, of course, some of the highest among young adults ages 18 to 25. They find that about 14 million Americans which it equals out to about 9% of people that are 12 to 17 and 22% of people 18 years of age to 22 are current illicit drug users. And of course, still with marijuana, especially in our state, still being illegal, that is the most commonly used illicit drug, excuse me, at 46%. I'm sure it's a little higher now. And as we know that there is a new epidemic of heroin abuse, and we're definitely seeing that in Louisiana, specifically in Baton Rouge. And excuse me, the non-medical use of oxycodone is very rampant as well. So different cultural issues that we look at, same thing. I think these are just kind of interesting, nothing I'm going to test you on, but alcohol is the drug most widely used by African-American youth. African-American youth use both licit and illicit drugs at, do you think, lower or higher rates than Caucasians? I know y'all are on mute, but it's actually lower rates than Caucasians, but they experience more associated health and legal problems. And I think that's important to know. Drug use is high among Mexican American and Puerto Rican adolescent boys. Cuban Americans report the lowest percentage of problems. Use is lowest among Asian and Pacific Islanders, and highest among Native Americans and Alaskan natives. And then men, do you think they're more or less? They're actually more than women. All right, so etiology, all in all, of course, we know that it's going to affect the whole biopsychosocial etiologies for patients. So just to kind of talk about those a little bit, of course, we know there's a genetic predisposition. If someone in your family has a substance abuse problem, you're at a higher risk of getting that. We do find that it actually increases the people that have addictive disorders have increased levels of dopamine. Thought that was kind of interesting. Usually they find that usually they have low self-esteem. There's environmental factors involved. Of course, psychological, which I think is a huge part that we'll talk about. Depressed mood and inability to cope. And those are going to be, of course, really important, and we're going to focus on those. So first, we're going to talk a little bit about alcohol, okay? I know some of this y'all are going to know, so like I'm not going to go into too much, but I want to focus on, excuse me, a few things that I think are very important when you're taking care of someone in the hospital setting. So, of course, we know it's a sedative, anesthetic found in various proportions in liquor, wine, and beer. Okay, and it's always really important. I'm just going to say this now in case I kind of forget to mention this, to note what type and how much your patient is drinking. Because, of course, 2 beers in comparison to 2/5 of liquor are a big difference. So something to kind of think about. It's always important to find out what they are drinking, the type. Of course, we know it depresses the central nervous system, and of course, it depends on how much is consumed in a given period of time and how rapidly the body metabolizes it. And that's going to go back to that tolerance we were talking about, okay? So normally when someone doesn't drink, they say that a body can metabolize 1 ounce of liquor, a 5-ounce glass of wine, or a 12-ounce can of beer per hour without intoxication. I kind of laugh because I don't know if that's, I'm a lightweight, so I don't know about that for me. But like I said, that goes back to the tolerance as well. Let's see. Somebody asked if I could repeat the definition. The definition for what? I'm sorry. Alcohol. Oh, okay. It's a sedative, anesthetic. in various portions in liquor, wine, and beer. Okay. Of course, excessive use we find can cause a lot of adverse effects in different body systems. Your book is really good about discussing those, but just in general, and I'm sure you've seen this on some of your patients, but peripheral neuropathy, esophagitis, gastritis, pancreatitis, all the itises, everything becomes inflamed, right? Hepatitis, cirrhosis of the liver, which when somebody gets a cirrhotic liver, of course, we can see portal hypertension, ascites, which is that third spacing, but in the abdomen where they look real pregnant, right? And of course, leukopenia, thrombocytopenia, things of that nature. I do want to talk a little bit about alcohol, blood alcohol level as well. Okay. There we go. Blood alcohol level. Usually we'll see, and you know, I'm a person, I like to involve y'all, so it's so hard that y'all are quiet. But what is the legal limit of alcohol when someone's driving? Does anybody know? Y'all can just chat it, or I think most people know it's 0.08. Okay. So, you know, that's a percentage. When they actually bring it down into the DMs per whatever they call it in the labs, it actually is to the 10th place. So in a hospital, your blood alcohol level is going to come out, let's say it was 0.08. It's actually going to be 80 in the hospital. And I tell you that because you will see patients come in and you're going to see an alcohol level of 300 and you're going to be like, wait, what? What's going on? I thought it was 0.08. And it's just, of course, a different type of lab that that they have figured out in the hospital. So I let everybody know it's milligrams per deciliter. So anyways, I will tell you from my experience, usually I see, you know, anything up until the 300 to 400s. When somebody's over 400, they probably almost died. Okay. I've had people that they've been that high that actually have died, of course. I think one time I had a student, had a patient who his was like 420, and I was just like in awe that he was still with us. Like, it was pretty amazing. So usually we'll see like if they're really sick, high 300s, but you don't see a lot over 400 because they usually passed away. So that's just something to think about as well. I know on our acute setting on St. Clair, since we are separate from the hospital and the ER is across the street, we don't like the patients coming from the ER until their blood alcohol level is usually under 200. And that's just because that 200 to 400, wherever they're at a high risk of having a seizure and things of that nature, having a lot of complications. I think that is all I wanted to say about that. All right. Some biological responses to alcohol. So like we said, is tolerance. And of course, that is when they have a more rapid metabolism of alcohol and a decreased response to the effects. So just like certain other drugs like opiates, there's a tolerance issue as well. So the more you drink, the more you have to drink to get the same desired effects. Okay. So I always give this example, like with an opiate, like someone that let's say they started taking Lortab and they started to misuse it. And they're taking maybe the highest dose that they can take 4 times a day. In time, that's not going to help their pain at all. Okay. And even that, I mean, I'm sure y'all probably taken a pain pill in your life. It kind of gives you that sedation or that sedative feeling. You're not going to have that. You're going to lose lots of those effects. So, of course, that's why they have to take more and more to get the same desired effect. And it gets very dangerous. Alcohol withdrawal. So this is when someone is actually going through a detox, okay, and they're going to be withdrawing with us. And we do see this in the clinical setting, in the acute care setting. We see changes in their vital signs. So, you know, I would normally ask you what you think. Do you think the blood pressure goes up or down? Anybody want to chat on here with me? It actually is going to go up. Yep, you got it. Good job. So what about heart rate? Same thing. It's going to go up. Okay, so these people are going to get very hypertensive. They're going to get very tachycardic. We're going to see a lot of diaphoresis, GI problems, which of course GI problems, you know, we can deal with and we can give PRN meds, but you still look for those things. And then CNS effects, of course, hand tremors, restlessness, okay, no fun. So also, this is where you would see an ASC done, okay? And I think I might talk about this a little bit later, but I'm just going to mention it here. So an ASE stands for Abstinence Symptom Evaluation Scale. And with this, hopefully some of y'all have seen examples in your clinical settings, things of that nature. But they actually get a number for the different things that I've acknowledged here. So like vital signs, it will say like if their vital signs are within normal limits, it will be a 0. If it's like above 100 to 110, they'll get a 1. 110 to 120, they'll get a 2. Okay, so they're going to have numbers to each thing. It's a scale. And what you do is then, of course, it's going to ask if they're diaphoretic. Do they have mild, moderate, severe? Are they sleeping? Do they have sleep problems? It will ask about hand tremors, and it wants you to check for mild hand tremors. Have them hold their hand out. Remember the fine hand tremors we've talked about? You're going to only see them when you have them hold their hand out, okay? Moderate is more where they're drinking their water and they're starting to spill their water. You can kind of notice it. And then, of course, severe is where they can barely take a sip of water, okay? But for mild, I just always like you to know when you're assessing that, make sure you have them holding their hand out. So with these things, that scale, that ASE scale, the higher the number, the higher the chance, well, the more they're detoxing and the higher the chance they're going to have a seizure. Okay, so that's real important for me to note. So usually when somebody is detoxing, the doctor will put them on ASEs, and it stands for Abstinence Symptom Evaluation Scale. So some doctors will say if their ASE is greater than a 5 to maybe give them some Ativan IM as noted in the PRN, okay? Thanks, Taylor. Taylor wrote it out for y'all, so thank you. I think I do have it later on in the PowerPoint, but just to make sure. Now, alcohol withdrawal delirium, this is a medical emergency, okay? This is not part of withdrawal. This is a medical emergency. Now, this is when someone actually, we find, I'm sorry, usually, let me just say this, usually with the medical emergency, you can probably decipher, but usually death can occur even if it is treated. And so you really have to be careful with this. Now, what are you going to see? Usually with this, they do show the signs, the regular signs of detoxification, but the big thing is they become psychotic. So remember, we talked about psychosis as being they hallucinate, they're delusional. So I know at first, I thought that was a common sign of someone detoxing. It is not, okay? If they are hallucinating or detoxing, if they are hallucinating or delusional, they're psychotic, and they are at a real high risk of death, okay? Usually the death occurs because a result of sepsis, an MI, a fat emboli, peripheral vascular collapse, electrolyte imbalance, of course, aspiration pneumonia from, of course, having seizures. So these are things that we really want to check for, okay? One of the biggest things that you're going to see, of course, is a change in their level of consciousness. We see autonomic hyperactivity. And like I said, psychosis is a big thing, okay? And they can run a fever. So that's something you want to watch out for. So medical emergency, when we see this, this is a big deal. I like to just give a little example here. Years ago, when I used to bring my students to Baton Rouge General Hospital, we actually, the Jerry Psych unit. Actually, at this time, it was the Med Psych unit, I'm sorry. And we would get a lot of detox on this unit. So there was one patient, you know, I always ask the nurses, you know, if you're good patients for my students, that kind of thing. And they let me know. Well, this one patient, of course, was hooping and hollering and very, very loud. You know, the one patient everybody wants to stay away from, right? Because we're like, oh, they're hollering, they're going to hit me, whatever, right? So the nurses told me, just don't give a student that patient. They're pretty sick, okay? So here, the man is hooping and hollering. Every time he walked past his room, he would just scream bloody murder. And of course, all the students are like running past his room, you know, and he's screaming, help me, you know. He actually was in restraints. And I noticed that when I was walking by his room. And of course, I just felt terrible. This guy's screaming and nobody's really going to check on him. And, you know, we're passing his room over and over again. So I went into him and I went in and was like, okay, hey, what's going on? You know, and I could tell he was very confused right off the bat. But the biggest thing he was screaming was, there are spiders all over my wall. Kill the spiders, kill the spiders. And I'm like, hey, sir, there's no spiders. Well, here I found out I'm actually going through alcohol withdrawal delirium. Very dangerous. And we had put him in soft wrist restraints. Like, how terrible is that, right? I'm just increasing his risk for increasing that risk for death and all that kind of thing. You know, I'm sorry, I got a question. Let me see. It really depends. That's a good question, Blair. Blair asked that one thing with withdrawal delirium. How long do they have until they pass away? And that's a good question. It really depends. They could have a seizure and actually die right there of aspiration pneumonia. It really depends kind of what they die of. So the biggest thing is you start to see that psychosis, you want to go ahead and call the doctor and make them aware if this is something new with that patient. So good question, Blair. But this guy was just screaming about the spiders on the wall. Now, if I was having a problem and I was psychotic and seeing spiders all over my wall, I would be terrified, number one. And then you went ahead and you tied me to the bed. Like, does not make a whole lot of sense, right? So, yeah, that was definitely not the best thing to do. And, you know, that goes to show you that restraint should be the last means, as we always talk about. And the one problem was he was confused and he was standing up and trying to get out of bed, and they were concerned he was going to fall his head. But with that, this patient would need to be a 1-to-1. Okay, that's when I'd be doctor. And then probably, like I said, something else is going on with them that they need to go ahead and check out. He's probably got something significantly wrong with him. All right, the alcohol-induced anesthetic disorders I'm going to touch on. These are things we always look when we have a patient that is withdrawing from alcohol. So, of course, we know that alcohol is directly toxic to the brain, and it can cause atrophy of the frontal cortex, and then it eventually causes chronic brain syndrome. Okay. With Wernicke's, we see this. It's caused by a thiamine deficiency. Okay. It's not exclusive to alcoholism, but we see it with alcoholism. So this is always something you want to make sure that you're looking for. Now, usually you will see your patients that are detoxing from alcohol, they'll go ahead and they'll give them what they call a banana bag. Okay, some of y'all probably are familiar with that term. It's just a liter of IV fluids, and they pump a ton of vitamins in it, and it turns yellow. So that's why they call it a banana bag. But of course, there's going to be a lot of different vitamins, but especially thiamine in this. Okay, they usually give them that first thing in the ER when they come in. And if they need another liter, they'll give them another liter. They will also give them IM thiamine or B vitamins, usually for a couple days that they're there, the first couple days of detox. Then after that, they'll just usually give it by mouth. So if you have somebody that is actually detoxing, they're usually going to be on a ton of vitamins, especially B vitamins and thiamine. And that is the case. We're trying to prevent Wernicke's. So what Wernicke's is, it actually is an encephalopathy that happens because of this brain syndrome that we talked about. So we want to kind of combat it by giving them a ton of vitamins at the beginning. But usually what happens, they get very dizzy, they get very confused, and we start seeing some different dysfunctions of palsy and different things of that nature. But confusion is a real big one. And when I say confused, these people are very confused. Lots of times with these patients too, they they forget their family. It's a huge confusion, and they don't always get it back right away. Okay. Another one is Korsakoff's psychosis. Okay. Korsakoff psychosis, this is what they also call alcohol amnestic disorder. So it's characterized by both retrograde memories prior to the event or loss, or antegrade loss of ability to create memories after the event. But it does spare the intellect. So confabulation, we talked about before. Does anybody remember where confabulation came into play with diagnosis? It's actually the neurocognitive disorders, specifically Alzheimer's. So confabulation, people will make up, it's telling a plausible but imagined scenario. It fills in memory gaps. So like if somebody has, we see it, like I said, with Alzheimer's, where you ask them how many children they have. And who wants to say, I don't know how many children I have, right? So they'll confabulate. They'll say, oh, I have 3. And then maybe you go back to the chart and see this patient had no children, okay? That's just a type of confabulation. I know sometimes as students, we kind of take it the wrong way. We feel like our patients are lying to us or something of that nature, but it's not. It's usually because they're embarrassed to tell you they don't remember, okay? And of course, this happens with Korsakoff's. You have to think, when somebody drinks, sometimes they black out and they don't remember what happened, and they might confabulate, okay? So with the treatment of alcohol withdrawal, and I know I'm spending a lot of time on alcohol, and you're like, Miss Tusa, we're never going to get through this lecture, but alcohol and benzos, like I said, can be deadly detoxes. So this is where I'm going to spend the most time, okay? With alcohol withdrawal, when somebody is detoxing, we actually give them benzodiazepines. And you're probably like, what? Why am I going to give them a benzo? Something else that's addictive, right? But you want to think, what is a benzo designed to do? If you look up the classification of a benzodiazepine, one of the things that it will say is anticonvulsant, right? So we're trying to prevent seizures. Benzos also help with different things like, of course, we know anxiety, which anxiety is a huge thing when somebody is withdrawing from alcohol. It'll help, decrease their heart rate, blood pressure, helps relax, those kind of things. things. So they usually give a benzo taper. And I will tell you, it's just going to depend on what benzo that the doctor prefers. I've seen all kinds of benzos used. I know at the lake, they usually use Ativan. And so when I say a taper, it would be something ordered like Ativan 2 milligrams PO, Q6 hours times 8 doses. Then decrease to 1.5 milligrams every 6 hours for 8 doses. Then decrease to 1 milligram. You see what I'm doing with this? And that's because we just don't want to shut it off where they have a seizure. And it usually helps the other signs and symptoms of withdrawal as well. Okay. I also find, and this is probably, let me see on my next slide. No, it's going to be one further down, but we'll skip over it. I'm going to talk about it now. You'll also see that lots of times they'll put these patients on a catapress patch, which of course is going to help decrease heart rate and blood pressure. We usually stick those little patches, usually on their back or something, so it's not confused with their nicotine patches if they're getting one on their arm. Catapress patches are usually good. And I should know this, but I haven't used one in so long. I want to say for 7 days. It's either 3 or 7. I can't remember. But anyways, of course, check your order for that. But and I just tell you too, you want to be aware of that. If let's say their pressure starts going down too low, well, we need to talk to the doctor about getting that catapress patch DC'd. Okay, so just something to kind of think about. But at the beginning, lots of times they will put them on a catapress patch. Let's see. And then antipsychotic meds, of course, they will give those for psychosis and different things of that nature, like that patient I was telling you about. But you still have to be careful. We don't want to act like that psychosis isn't happening. If I'm giving them antipsychotic, we know that that's going to decrease psychosis. So I don't want to just then blow it off and say, oh, he's not psychotic anymore, so he's fine. No, that he's going into alcohol withdrawal delirium. So you still have to be careful. You don't just want to misuse those antipsychotics, okay? Sure, the patch, somebody asked if I could repeat what the patch is for. It's a catapress patch, and it's used to decrease blood pressure and pulse, which we see a lot with alcohol withdrawal. Next, a few drugs that I like to talk about with the treatment of alcohol dependence, okay? So sometimes you will see that some of these drugs are used to actually kind of deter the patient from drinking after they are, detoxed, and maybe if they're in a rehab facility or whatnot, okay? So they don't use anymore is what we're trying to hope for. Antabuse is kind of an oldie drug. You still hear about Antabuse occasionally. I will tell you, I haven't seen Antabuse used as much in the last couple of years. It's not a treatment or a cure for alcoholism, but it can be used as an adjunct therapy, okay? So what it does, it helps deter individuals from drinking when they're on this drug, okay? So even if they take small amounts of alcohol and they're on Antabuse, they'll have adverse effects. So they'll start throwing up, maybe start feeling palpitations, things of that nature. So the thought behind it is they'll drink a little bit, they'll have these terrible effects, and they're not going to drink anymore, right? The problem is if they continue to drink, those effects go to more serious reactions. And we're talking serious, like respiratory depression, heart attack, arrhythmias, congestive heart failure. So what do you think was happening? A lot of people were dying, right? So with that, you have to really use Antabuse cautiously. And I think due to that, they have really stopped using it quite as much. I see it occasionally, just not like I used to see it prescribed, okay? Naltrexone is another one. This one you actually do see. I have seen this one used a lot more. Naltrexone actually originally was used for treatment for heroin abuse. It's now approved by I'm sorry, it's now approved for the treatment of alcohol dependence. They actually have naltrexone in daily doses, pills, or monthly injections. And what this does, it actually helps reduce the cravings, and it can help someone, of course, maintain abstinence. They say that it interferes with the tendency of someone wanting to drink if they're recovering. So if they do slip up and have a drink, it's not going to kill them, but it makes them not want to drink anymore. Okay, so this is one I do see that's used a little bit more. Your book talks about Camprel. It works kind of the same like naltrexone. I'll tell you, I've never personally used Camprel, but I have heard about it, and of course your book really talks a lot about it. Now, I have not worked in a rehab center for a long time, so I'm not I'm not real in tune of what they're using nowadays. So that might be something that they're using more. Like I said, I think it's more of a preference of the doctor. Suboxone, y'all probably heard of Suboxone. Suboxone is actually, it originally was used as treatment. No, I'm sorry. I always get those confused. Suboxone is treatment for outpatient detox. Suboxone is not one that I really love. It's kind of the methadone that they use for opiates, but used for alcohol. Okay. Lots of times people will then become addicted to the Suboxone. So that's why I don't really love Suboxone. They'll usually misuse it, and in time it does have a different type of effect, and people will crave more, and they'll usually misuse it. So it's not my favorite, but this is one they actually have to go to an outpatient facility to get that prescription. Okay, like I said, they'll also have a lot of vitamins and minerals that they'll need, especially at the beginning. And then there's that catarrh patch I kind of got excited and told you about a little early, but that's just another pharmacological treatment of alcohol dependence. All right. I think going into cocaine, this is a good place to stop. Like I said, I know we spent a lot of time on alcohol, and we're going to spend a little more time on a few other ones, but we'll be able to get through this a little more quickly now that alcohol is out of the way. It's 9:53, so let's take a little break and come back at 10:05. Okay.